seated. Dr. Said and Dr. Parvati. So my topic of discussion is the role of ultrasound in obstetrical emergencies. And what is an obstetrical emergency? A suddenly developing condition that occurs in pregnancy, during labor, or just after delivery, and requires urgent medical or surgical intervention, that is labeled as obstetrical emergency. And how patient presents. The two commonest presentations are the pelvic pain and the vaginal weakness. For others, they include the loss of fetal movements, retention of urine, excessive vaginal discharge, and prolapse of something per vagina. These are the various presenting complaints which patients comes to a family physicians. And whenever there is positive pregnancy test and the patient comes with a pain in the pelvis, etiological factors may be ectopic pregnancy. We should keep in mind it may be due to some abortions, bleed in the corpus luteum cyst, or torsion of a cyst associated with the pregnancy. We will discuss these step by step. Corpus luteum cyst, whenever ruptures, that produce free fluid in the cul-de-sac and the uterus and will produce pain. Likewise, a large ovarian cyst associated with the pregnancy alongside the pregnancy may produce pain. It may get ruptured or not. Presence of the large cyst is a reason to produce the pain in the pelvis. Second presenting complaint is the bleeding per vaginum in the pregnancy, and that is maybe physiological sometimes, not always pathological. Abdominal findings, they are diagnostic to rule out various causes. However, sometimes we have to go for the serious scans if the initial one is inconclusive. The various physiological factors which produce the pain in the early pregnancy, they may be placental causes, fetal or uterine causes. Placental causes, they include the subchorionic hematomas, abruptio placenta, low-lying placenta, and the molar change in the placenta. Fetal causes, they include the failed pregnancy, ectopic and vanishing in multiple pregnancy, and uterine causes, they include the uterine malformations, IUCD, alongside the gestational sac, pregnancy with fibroids, and sometimes there is a trauma, and patient comes with pain and bleeding from the vagina. We will see all these step by step. First is the subchorionic hematoma, which is a perigestational hemorrhage between the endometrium of pregnancy, that is the decidua, and the wall of the uterus. You will see that hematoma or anechoic area around the gestational sac in these pictures. And we have to see whether it is how much. If it is less than 60 ml, the prognostic value is good. If it is more than that, it is abnormal. However, we have to rescan the fetus, and it appears as an anechoic, crescent or wedge-shaped area. You can see here in this picture. This is small amount of hematoma, and here is the large amount of hematoma. And if it is more than 60 ml, this is a bad prognostic. Abruptio placenta is the abruption of the placenta, and it may either be complete or partial, and abruptio placenta is labeled when the pregnancy is more than 20 weeks of gestation. Before 20 weeks, it is subchorionic hematoma, and later on it is labeled as the abruptio placenta. The typical pathological injury is the retroplacental hematoma. We see a hypoechoic area posterior to the placenta. Sometimes this is not so easily visible because fresh bleeds that looks like placenta. When it becomes hypoechoic, we can see it clearly, and you can see in this picture this is a retroplacental hematoma in a case of abruptio placenta. Placenta preview as the implantation of the placenta over or near to the internal mass, and there is disc of bleeding because of thinning of the myometrium. Here the placenta, volar placenta line, the lower uterine segment, and this is the central or typhoid placenta previa. And here the placenta is coming from the posterior aspect, covering the osmosis, type 3 or margin, type 3 placenta previa. The molar change in the placenta is a benign change, and it may either be complete mole or partial mole. complete mold when whole of the placenta undergo the trophoblastic changes. You see the multiple anechoic area in a bright mass, snowstorm appearance, and as you see here, the complete molar change. But when there is visible gestational sac or embryo alongside, this is called a partial mold. When failed or failing early pregnancy, termination of pregnancy, or expulsion of the fetus when the fetus is unable to survive independently is labeled as abortions, and abortions may either be threatened abortions, inevitable, complete, incomplete, missed, or septic abortion. All these you can see at ultrasound examination. You see a gestational sac and embryo and yolk sac inside. Here is cardiac activity, but the patient comes with the pain or bleeding, then there is threat to abortion. So it is labeled as threatened abortions. And when the gestational sac is visible in the lower uterine segment and the cervix is incompetent, even though the sac is intact, cardiac activity is visible, that is inevitable abortion, means that abortion has to take place or the abortion is in progress. You see the sac in the lower uterine segment. So this is inevitable abortions when the sac lies in the lower uterine segments. Incomplete abortion, there is expulsion of the fetus or embryo with retained chorioreceptor tissue, which looks apogenic and irregular in leukodexis. Sometimes you can see the flow on the doctor, so this is the case of the incomplete abortions. Retained POCs or chorioreceptor tissues means that it's an incomplete abortions. Missed abortions when the fetus or embryo dies but is retained within the uterus. If you see a fetus or embryo of chromogram length of 10 millimeter and there is no cardiac activity, it is a case of missed abortion. As you can see here, this is an embryo. There is no cardiac activity but it is retained within the uterus, so it is a case of missed abortions. The ectopic pregnancy is very important to keep in mind when patient comes with pain or bleeding and there is hysterectomy or pregnancy, and it is the implantation of fertilized ovum at the sites other than the uterine cavity. The fertilized ovum is ectopically implanted, and various sites where it can be that maybe the interstitial within the tubes, within the ovary, the cervix, the cesarean scar, these are the various sites where we can see it. And at ultrasound examination, we will see the free fluid, the cul-de-sac, we will see a thick wall cystic in as an axial region on the right or left of the uterus, and that thick wall cystic area sometimes we can see the embryo within it, cardiac activity may or may not be visible. And you can see here this endovaginal scan, the cellularization of the endometrium of the uterus is there, and at an axial cystic area, thick wall, and with presence of the cardiac activity. So this is a right side impact of pregnancy. Interstitial pregnancy is the implantation of the gestational sac within the intramural part of the fallopian tube. At this side, there is implantation of the sac that is called the interstitial pregnancy, and in ultrasound we see a sac with thin myometrium around less than 5 millimeter. And you can see here this is the transabdominal examination, and this is the endovaginal. You see a sac at the corner of the uterus, and the distance between the sac and the myometrium is less than 5 millimeters. So we suspect the interstitial pregnancy there. The cervical pregnancy, the sac implanted within the cervix, that's the cervical pregnancy. And you can see here, this is the endovaginal scan, the sac is here in the cervix. Then cesarean scar pregnancy is a gestational sac implanted in the C-section scar. That is called the cesarean scar pregnancy. As you can see here, again there will be thin myometrium around, and this will just close to the scar, close to the ischemic area. Ovarian ectopic is very rare, and we see the ectopical placed gestational sac within the body. Then sometimes, very rarely, we see the abdominal pregnancy, which is the implantation of pregnancy within the peritoneal cavity, that's the outside the fallopian tube or the ovary. And heterotopic pregnancy is the simultaneous visualization of the sac both inside the uterus and outside and then the adnexa. This is the retrograde pregnancy. Again, this is transabdominal, the sac is visible inside and outside the left adnexal region, and this is the endovaginal scan. So this is the heterotopic pregnancy, simultaneous visualization of the sac within the uterus and outside the uterus. Next cause is the disappearing or vanishing twin. There are multiple pregnancies. One sac of embryonic size is normal with visible cardiac activity, and second sac embryonic contains no cardiac activity. So this is vanishing twin. One fetus is dying and the second is normal. And sometimes there is uterine malformation. There are two horns, right and left. Left horn have pregnancy and the right is empty. So patient may present with the bleeding for vagina in this case. In other patients with pregnancy in one horn of the uterus, the other is empty. Then pregnancy with IUCD, intrauterine contraceptive device, we know this is appears ectogenic. There is normal alive embryo, and here is the copper T placed alongside it. Then sometimes there is fibroid alongside the sac, and you can see hypoechoic area and you see the gestational sac. So this is pregnancy with fibroid. A large fibroid with calcified wall and pregnancy inside the uterus. So the pregnancy with fibroid may produce pain as well as pregnant vaginosis. Trauma, if there is history of accident beside the maternal shock, the processes that contribute to the fetal loss, they include the direct fetal injury. There may be the rupture of the uterus. However, the abruption placenta or rupture of the placenta is a common spot. Whenever there is the abruption placenta, there will be a hematoma or hypoechoic area posterior to the placenta, between the placenta and the margin of the uterus. And here is a case where there is a lot of hemorrhage inside. The baby is dead and there is history of the trauma, direct trauma or direct fetal injury causing the intrauterine fetal demise as well as the pain plus bleeding vaginosis. The next presenting complaint is the loss of fetal movements that may be associated with visible or non-visible cardiac activity. Patients complain that the movements they are sluggish or less, and we have to see whether the cardiac activity is there or not. If there is no cardiac activity, of course, it is a case of the intrauterine fetal demise. And various other parameters to see the demise is the soft tissue edema of the skin more than 5 millimeter, then gas shadowing within the fetal vessels, that is a Robert sign. There may be the gross distortion of the fetal anatomy, and you can see here the fetal skin edema appear within 24 hours after intrauterine fetal death. The Robert sign, which is the visualization of the gas within the fetal vessels, that appears 24 to 48 hours after the death. The scalding sign is the overlapping of the scalp bones that appears 7 hours after the fetal deaths. And you can see here the scalding sign, the overlapping of the scalp bones. If there is loss of fetal movements but the cardiac activity is absent, we should go for the umbilical artery flow. If the umbilical artery flow is less, then it is mild placenta insufficiency. If it is absence, it is moderate, and if there is reversal of the umbilical artery flow, that is the severe placenta insufficiency. This is the normal high systolic and diastolic flow. Here the less diastolic flow, and here in this case there is the absence of the diastolic flow of the umbilical artery, and here it is the reversal of the diastolic flow. This is the severe or marked placenta insufficiency. Urinary retention is another presenting complaint. Sometimes the uterus is retroflex that produces the push on the cervix and so produce the retention of the urine, and when the uterus becomes abdominal after 14 to 16 weeks, the retention is not there. It is a transient or temporary condition seen in the early pregnancy. Large cervical fibroid may also produce the retention of the urines. Excessive vaginal discharge, it is the spontaneous rupture of the membranes, is the leading cause of excessive discharge of vaginum in the pregnancy, and at ultrasound you will see an alive fetus, but there will be no amniotic fluid around the fetus. There will be the oligo, hyalurnia, or anhydronias. Prolapse of something, vaginums, it may there be the prolapse of the membranes or the cord prolapse. If the membranes are prolapsing, there will be the shortening of the cervix, and you will see the widening of the cervical canal as well. And when there is a cord prolapse, you will see the cord within the vital cervical canal. And if there is only membranes, that is, if the cervix is intact or there is not rupture of membrane, that is the vasa previa. If there is rupture of membrane, that is called umbilical cord prolapse. That is the last slide. There is the cord in the vital cervical loss. And with that, thank you very much.